So we are ready to go for our July meeting. There's only, 9 of us, but I think we'll be okay. We'll record it, and then if people want to watch later, they can watch it, and then also we'll send out the slides. So project updates, next slide. So we're making progress on a lot of different pieces. The qualitative surveys, we now have 100% completion. As a reminder, that was 5 different people at each of 5 different sites to get some qualitative input on, you know, how we did, what were facilitators and barriers to our implementation. And the qualitative team is now working on a manuscript. We haven't seen the manuscript yet, but they're gonna have something for us hopefully within the next few weeks. And then as we move forward, we'll show it to everybody else as well. We have a lot of good data from the cost of implementation. Joe Levy, who's running that, has data from all the sites, from all the different surveys that people have provided. So that's moving ahead. Now that we actually have manuscripts in draft form and we're writing and working on them, we are working on this group authorship listing, which Lizette is driving, and we'll show you what it looks like on the next page. We definitely still need more input from the 4 sites that are listed here. So Lizette will continue to follow up with those 4 sites, so we know who the group authors are. Lizette, I think the next slide has where we stand right now. I realize it's hard to read, but as you look at it, you'll see, not a surprise, there's multiple people from Hopkins, multiple from Center, and then each site in general, we've suggested basically most places will get 2. There are a few that will get 3. So for example, the San Diego site is having a change in their local PI. So they're going to include both the old and the new as one example. So we've got a bunch of the places that are moving forward on that, and then Lizette, you'll work on those last 4 to get the names and then confirm to make sure we've got all the right people.
Yeah, I'll touch base with those 4 sites just to be sure.
Perfect. Okay, so that's really good. Questions or comments about that piece? If you guys go back, if you can go back 1 slide. So the way this is going to work for a bunch of the different papers is there'll be a writing group for each of the projects that will list, some of the people, and then the group authorship it'll be, for the CLOTT 3 group, and many of you have been involved in projects like this before. So everybody will get authorship credit for these papers that come out of the big group. So that's kind of our plan for that moving forward. Okay, thanks. Next slide. So data update, as you can see, this is looking really, really good. We have a whole lot of green. There's only 1 site left, which is looking, this is for the VTE prophylaxis data pull. Really, it's just MUSC. They sent us a version of data. It needed some tweaking and updating and fixing. So we're in the process of that. I don't see, hold on a second, let me see. Is Bruce on from MUSC? I don't see him. Okay, I don't see Bruce, but we are actively involved in working with them to get this last piece of the data, because it's obviously 8 out of 9 is great, but we need the 9th site. But thank you for all the sites that have gotten their updated data. There was a few IRB issues and things to work through. So thanks for everybody making this a whole lot of green. I appreciate it. Next slide. So we're going to switch gears a little bit. And what we've done for the past few months, as people know, is we mostly have been kind of talking on where are we with the data, what do we need to do, etc. Now that we're really done with that mostly, and really just have the 1 data site left, what we're going to do is switch gears a little bit to a few of the projects. We're going to talk about a few of them today. Some of them are, the first 2 are mostly done, and you should be seeing manuscripts for them both shortly. And then we're going to talk a little bit about the main data project as well.
How are
So
you?
I'm going to talk first about the nurse education survey. So if you go to the next slide. So this, so this is an abstract of what the paper is kind of going to look like. And I realize it's hard to read every little item, but I'll just tell you, as a reminder, when the nurses did the online education, at the end of the education, they were invited to take an online survey that asked a bunch of information about their opinions of the survey. We got 800 responses back from nurses at all these different sites. And there's a lot of really good data. And in conclusion, basically the summary is the nurses liked it and they liked this education better than other education they get. And they feel it's directly applicable to their practice and they're going to use these skills. So in general, we were pretty happy with the survey results. So that's kind of what the abstract looks like. And then I didn't put all the text, but I did cut and paste some tables in, and we can just quickly run through what the tables look like. So next slide. So the first data table, these are fully de-identified. So it's just site 1, site 2, site 3. It doesn't name any of the hospitals. It tells you how many nurses did the module and then how many nurses did the survey. The response rate, once they've done the module, is anywhere between 75 and 98%. But in general, it's really high no matter what. Even the site that had the lowest response rate was still 75%, which is great for a survey. And like I said, this totals over 800 nurses giving some feedback. So next slide. I will say, as we're going to the next slide, if you guys have questions along the way about these different projects, please chime in. It's hard for me to see if people raise their hand, so feel free to just say, hey, Elliot, I have a question. This is table, so that was table 1. This is table 2. This kind of summarizes the nurses' opinions. It's these are the questions that we asked. This education module directly applies to my practice. 95% said yes. This education module will help me communicate better. 90% said yes. Like in general, there's really strongly agree to many of these things. I enjoyed this module. I found it engaging. And the last one, which we really liked, is I like this module better when compared to other online clinical education I've taken. 75% said they like it better. Then it's not like it's good enough, but it's actually better than other stuff. So we thought that was a pretty nice number. And these are the overall answers to all the different surveys. Next slide. This is a little bit of the thematic distribution. So in addition to the Likert scales, agree, disagree scales, there was a write-in category, and Femi, who was our postdoc, reviewed all those. There were mostly, there were 100 people who gave some sort of written comment. More were positive than were negative. The negative ones are not to be a surprise. Some were technical and formatting issues. This was originally formatted to be done on more of a desktop because that's how more education was done earlier. But now obviously people are taking it more on phones and mobile devices. So part of it was formatting, and part of it was this was very specific to one EHR. And if you're not using that exact version of that EHR, it feels a little different. So I'm not surprised at the negative suggestions. And we're actually working to potentially change some of those. So that gives a feel of what the positives and the negatives were like. And then if you go to the next slide, this is the answer to that question of how would you rate this education module compared to other online education? And, you can see a lot more in the 8, 9, 10s that it's better than others. And this is the overall for all the groups all together. Same thing. It's pretty happy to see that people liked it better, certainly not worse. Next slide. And then the last one is this one. It's obviously very hard to read on a small scale. And we think this might be the way to show that there's not a big difference or variation by site. It's not that some sites loved it and some sites really hated it. There does seem to be one site where the question of, I like this education better compared to other education. Most of the sites were around 80%, 75%. There's one site that's about 50-50. So I suspect there's one site where they do nurse education great. And this is not quite as good, but in general, 8 of the 9 sites are pretty high up there as well. Same thing about this question at the very last one on the bottom. How does it compare to other education? So that's kind of what that paper looks like. Any comments or questions on it? And like I said, the main takeaway is the nurses don't feel put upon to do it. They don't think it's onerous. They see the value in it, and they do think that the way it's been done has been done well. Comments, questions, or concerns? Okay, great. And like I said, we're working on the draft. It's going back and forth in the writing group before it goes out to the full group as well. Next up. So the next thing I'm going to run through is kind of the same thing. We had a different postdoc who worked on this. This is the Delphi survey. If you all remember that we asked the PIs at each site to help disseminate this out to the clinicians at their site of when should we hold prophylaxis before what types of surgery and procedures in trauma patients. So we're going to show you kind of the results of that as well. Same thing, that draft is in draft form that we're still working on. So we got 179 participants to answer the survey, which I think is great. It's a lot of people with a lot of expertise. As you might imagine, they're mostly trauma and acute care surgeons. But when you look at the list, there are other people. There are people that do critical care, interventional radiology, neurosurgery, orthopedics, plastics, it's vascular, etc. So there is input from multi-specialties, not just us as trauma and acute care surgeons. Next. Mostly physicians, but there are some that are advanced practice. The number got messed up a little bit, but it's the vast majority are physicians, 90% physicians with some advanced practice in there. And we asked about input about race, which is on here. And then next slide gives you a little more feel of ethnicity, gender. Keep going. The formatting doesn't work perfectly on there, but we'll make sure it's better when we send it around for everybody. So the most important takeaway message is probably on the next couple of tables. So this table is the first table where there is procedure, where there was consensus to an agreement to never hold prophylaxis for this procedure. And you can see the number of participants who voted on each one of these things and the percentage of, and that might be different for each thing. Not everybody answered every single question. We don't necessarily want, a gastroenterologist talking about IVC filter placement as an example. But there is consensus here on this list of items, and you can see the percentage in the parentheses. 97% said never hold it for central line. 97% never hold it for dialysis catheter, etc. So for a bunch of these different pieces, there is strong agreement that we don't need to hold DVT prophylaxis. And I think this will help guide clinical practice because we hear this problem all the time. Next slide. There's this longer list. This table is so long it didn't fit on one slide. There's a bunch of agreement on all these pieces of these patients don't need their prophylaxis held, and therefore they will not miss doses if you continue this going on. So next slide. And then this is the last little bit. I forget the exact number of items. I think it was like 25 or 30 things came to consensus. Consensus we stated was going to be 60% or above of people that said to never hold it. That was consensus. And there were a ton of these procedures that came to consensus. The second part is table 3. Next up. These are the procedures where the consensus was achieved where you should hold VTE prophylaxis. And this is, I think, equally as important, where we agree you should not be giving prophylaxis in patients who are getting intracranial surgery, epidural anesthesia, craniotomy, craniectomy. Interestingly, the G-tube one, it was not that's not how I voted, but what are you going to do? And then spinal anesthesia, etc. But I think there's agreement here of when you should be holding VTE prophylaxis. I think this table, is there one more slide of this table? I think that was it. Okay, so go back one. So in general, what that paper is going to look like is we got expert opinion using Delphi method from a multidisciplinary group of experts in trauma from the 9 sites. Actually, it ends up being from 11 sites because we included San Francisco, who was originally in, and we included Hopkins, who we're not putting in patient data, but we have clinicians. So the opinion, this is, group expert opinion, but I think it's still a good, strong addition to the literature. Comments or questions on that topic? Okay, so I would say, you'll be seeing these drafts of these papers. They are both, I would say, 80%-ish done and written. And obviously we can't send them out until we get the whole writing group agreed upon, and all the names and emails and everything like that, to make sure we have all the right people, which is that's going to work on. Then after that, we're going to get those papers going to the rest of the group as well. So those are the first two things we wanted to talk about. The next piece is, okay, now we're actually getting close to having real data for the whole project. We showed you the green where we are for the missed doses and the dose administration for all the sites. We have 8 of the 9 sites there. And then as a reminder, we're getting all of the data from TQIP. We expect to have the data hopefully in August. That's what they've told us, that it will be ready. And this will be all the data up to and including calendar year 2023. And we're going to go through the logistics of, number one, how do we actually get the data from you guys, and some of the steps that you'll need to help us with to get us the data. That's part number one. And then part number two is, once we have all the data, we have some empty shell tables. Like I said, there's no data in them yet, to show you what we anticipate using for our primary outcome paper. We have no idea what the outcome is going to be yet, but at least the idea of, this is what the analysis is going to look like. Here's an empty table 1, empty table 2, etc. So Brandon, are you still driving, or are you by any chance back in front of a computer?
I'm actually still driving. I just got through the tunnel, but I could talk through this if that's all right.
I'm totally fine with that. And then Lizette will kind of run the slides. I can prompt you as to which slide it is, and then you can walk through it if you don't have it memorized.
Sure.
Okay. So the goal here, this is the goal slide, which is, and I'll let Brandon talk to it after I read the underlined part. The key is, we need an encounter number added to your trauma registry for every single patient admission. So Brandon can then link the TQIP data with all the TQIP stuff, as you might imagine, to the dose administration data. So Brandon, you're up with that slide.
Yeah, so for each of the sites that have sent the VT prophylaxis data, you've probably sent us slightly more than what will be included with the trauma population. And so when we can join the VT prophylaxis data to the trauma data, that will be the refined total trauma population. But in order to do that, what we really need is the encounter number associated with each encounter within the trauma registry. So the college is going to be sending you in very near the trauma data compiled for this entire time period, 2019 through 2023. And that brings us into really step one. So next slide. So confirming that the individuals that the college believes are the designated individuals to receive the trauma data. Effectively, they're going to make this trauma data available to the people that they have on their list. They've provided the list of those individuals with names and email addresses to us. And we'd like you to go through that list and confirm that those are the people who should be receiving the data. Have a little conversation with them if they're not already familiar with this project, that they'll be receiving the data, and give them a general understanding that we'll be asking them to add an encounter number onto the data that they'll be receiving. Now, depending on how your trauma registry is structured, if you don't already include your encounter number as part of it, you might need somebody from your EHR reporting team to help consult with this to be able to pull encounter numbers from the EHR. And I'll talk about this in later slides in a little bit greater detail. But on the next slide is the list of individuals that were provided to us by the college of who they're saying are the designated individuals to receive the trauma data.
And
We'll be
Brandon, if I could
sending
just,
this out at,
I was just gonna say, I
sure.
was gonna talk to this, you know, you, obviously the people at each site know exactly who this is, who this person is. Some of the people are the ones on the call right now. But some of them are uninvolved in the project, so they'll just have to be the conduit they'll get the data and then give it to us, or give it to you at each site. You know, I see Joanne is on I think I saw Joanne on the call, and Joanne is listed here. So for that site, it's going to be easy, versus at Maryland, you know, I saw Rosemary on, and Rosemary, you're not listed here, but you know the two people who are running your data for TQuip. So it should make sense. We'll just have to make sure, because the college isn't going to send the email to anybody. They're going to only send it to their designated individuals.
Yeah. Sorry, Elliot.
No, it's totally fine. Okay, sorry, Brandon, keep going.
No. So making sure that everyone knows what's happening and getting everyone lined up in advance will probably save some time later. So step 2 is receiving the data. So the college will be sending data to each of the sites. They're estimating initially in August of 2024, but we'll certainly be keeping you updated as we hear more information from that. One thing that we would ask is that each site just generally look through it and make sure that roughly the number of trauma admissions that are being sent align with what you might actually expect for the population.
And that's the full
Next
patient
slide.
population. Brandon, I'm just gonna, so that's the full patient population. I know we talked last time, and Rosemary, you had a great question. You know, when you get data back, you get a TQuip population for the different TQuip subgroups. So this is gonna be the whole population. So if you submit, you know, 5,000 patients a year, make sure you get 5,000 patients a year back. This will not be just the TQuip high ISS, multi-system trauma, or single system, et cetera, that we're used to looking at. It's going to be the whole everything of all the data that you submit. So next slide.
Okay, next slide.
Yeah, you're on number 3 now.
So this is where we're asking you to append the encounter numbers onto the TQuip data. So what the college is going to send to each site includes a unique trauma identifier. There's no information about MRNs or encounter numbers or anything that you would be able to just identify from EHR data. They're going to send you a trauma identifier that you should be able to join to your trauma registry. Now, if you already capture your encounter number as part of your trauma registry, all you're going to have to do is join based on the trauma ID and add the encounter number to the tables that the college has sent to you, which would be the most ideal and easiest approach. Next slide. And that's sort of represented in this figure, and basically this will make clear sense to your data managers joining on the trauma ID to simply add the encounter number onto each of the trauma data sets that are being sent. However, if you're not including the encounter number as part of your trauma registry, that's where some other approaches might need to be employed in order to find the encounter number in the EHR. So next slide. This could actually require the trauma registrar or whoever receives the data to add different identifiers from the trauma registry, which could include the medical record number, the admission date, the discharge date, that would allow either them, if they have access to EHR data, or somebody on the IT team or the reporting team, to be able to join based on these MRN admission date, discharge date combinations to add an encounter number onto the trauma registry data. And the way that I've done it long ago trying to do this is that I would first try medical record number and admission date and discharge date as a way of trying to confirm that the correct encounter is referring to that admission. There are issues with this where the patient might be admitted overnight, and what's listed in the trauma registry may be different than what's in the EHR. So if there are unmatched records after trying to do that most comprehensive join of MRN plus admission date plus discharge date, I would usually try to do medical record number and discharge date. And then for any additional unmatched people, medical record number and admission date. And the next slide. This is sort of a graphic representation of having to go step by step to build the different identifiers to eventually get to adding encounter number. But it still ultimately leads to the same thing of having an encounter number associated with each and every admission in the trauma data that you receive. And I'm happy to meet with any teams about this as we're going through. So
And I'll
next
just
slide.
add as just for one sec, as the person who doesn't do the data join, and if some of you are thinking, I don't know what a lot of this means, the data people will look at this and be like, great, I can follow this roadmap and I can do this. And if they've got a specific nitty-gritty data join question, that's where Brandon can be helpful. But you know, I've had Brandon explain this to me a couple times, just as the person who's not actually doing the data management piece.
Could we get this emailed to us?
Yeah, so we will be sending the slides out, and we're
Okay.
actually working on a document
Yeah.
that kind of emails as a, you know, it'll be a Word PDF of here's step one, here's step two, here's
Great.
step three.
Thank
And
you.
that's where you can share this with the people that are doing the data for
Okay.
you, whether it's, you know, and it might be someone in your trauma registry working with someone in your EHR. You'll have to figure out exactly who the right people are, but they will have this roadmap in front of them to be able to do that. Keep going, Brandon.
So the fourth step of this is to confirm that all patients who are sent to you by the college actually have an encounter number added to it. You don't want any unmatched data. And, you know, there are issues where sometimes it doesn't necessarily even with
Brandon, we're losing you.
Yeah. So while Brandon's trying to get back on, I can talk to this slide. Base, Brandon,
So
we were having
what we
trouble
would
hearing.
ask,
Brandon, can you start over on this slide? I think we were having a little trouble hearing you. Let's see if we can hear it. Try it again.
can you hear me?
Yep.
Sorry, let me move to a different area. I just parked. So it's very important to make sure that every trauma patient who's sent to you from the college has an encounter number associated with their visit. This is the only way to ensure that we have 100% capture. So if you've gone through the process of first trying to append the encounter number from trauma registry, you've gone through the process of medical record number, admission date, discharge date plus medical record number, admission date, medical. If there are any unmatched patients at the end of it, we're asking that you please manually review and add the encounter number on so that 100% of patients will be included in the final data set that you would send to us.
And I will say,
So-
I asked Brandon the question of like how often this should occur, and I was told, Brandon, that the number should be very, very, very small. That the other ways of matching, doing all those other pieces, should capture, if not everybody, almost everybody, and there should not be a large manual piece for this.
That is very true. But basically, at the end of this, the number of matched appended encounter number visits should equal the number of visits that were sent by the College of Surgeons. And then next slide. And then the final step is to upload the data with the encounter numbers appended to a secure folder. Each site has its own overarching folder. We will make a trauma data folder as a subfolder available to each person, each site, and we will give access to the person that we're told to give access to for each individual site, for both the person who will be doing the data join and the PI for each site. And then we're asking that to just be uploaded as a single Excel spreadsheet, very much like what has already been done for the VT prophylaxis data. And that is it for the data join. If anyone wants to set up individual meetings with me or has questions, please feel free to reach out, unless anyone has any questions now.
I would say this is a time where if people have a general question, if you have a question, I wouldn't be surprised if some of the other people have the same question. So if there's questions about it, I think it would be helpful to talk about or talk through any of those questions or concerns right now. So I'll ask it a slightly different way. Does that make intuitive sense to people who use the data all the time? Does the general idea of we need to be able to link the TQIP data to the EHR data, and we need that linkage number, and that's going to be the critical part. And this will hopefully give you the step-by-step steps of exactly how to get that into the data for us. So that's the general idea. Does that resonate with people? I'm going to assume that means yes. Okay. Sounds good. I think obviously more to come. You know, we're going to send out some information of exactly how to do this for each of the sites. And I do have a feeling there will be emails and or meetings with Brandon to make sure we get the data the correct way. So more to come. So we're going to pivot over to, okay, now that you've been working on this project with us for literally multiple years, now the project is coming to fruition and we're going to actually have some data from the college. And now Brandon is going to show us some drafts of some, here's what the data is going to look like when we write the big primary main manuscript for the paper that asks the question, does the overall intervention work?
Can I ask a broad question that I should have asked earlier? What proportion of trauma patients do you believe will be prescribed VTE prophylaxis?
It's a great question. Could somebody, someone chime in? I promise not to hold you to it. I'll call on some people, but.
I'd say 100%.
100% are prescribed pharmacological, sorry, I'm going to clarify.
Yeah,
Pharmacological prophylaxis.
Yeah, I honest, I don't know the answer, but I think because that's the order set and that's what we do, it's just, that's what everybody gets. That would be my guess, 99 to 100%.
Okay, great. Joanne, did you come off mute to give an opinion?
I did. I'm thinking around 80% because there are those few in hemorrhagic shock, things like that. Yeah, I guess the timing is, I mean, if you define timing of VTE, eventually they either get VTE prophylaxis or they get a prophylactic or temporary filter, depending on what their issues are. So maybe 80, maybe 90, but I couldn't say 100 for our patient population.
Okay, anybody else feel like they want to chime in? And it's interesting, Rosemary, because at first when you said 100%, I was thinking, well, it's certainly not 100% on day one, but maybe by day 2 and 3, these people that, had solid organ injury and were delaying for 24 hours or
Yeah.
brain injury or whatever, I agree with you that later on, most of them should be getting prophylaxis. Maybe it's not 100, but
Yeah,
you
I
know,
mean, and you ask the question, like if you're, including how many, we send you patient information on patient X, they're gonna be on some during their hospital stay. I mean, it should be always less than 48 hours, but yeah, I mean, who wouldn't be on something?
no,
I
no,
would think.
and I personally think that's
Right.
I think that's probably about right. I would not have guessed 99%, but over 90,
Yeah,
somewhere
Well,
in that vicinity. I think early on at day 1, we know the answer from TQIP data is not everybody starts as early on day 1. We have that data, not just us, but it's been published
yeah,
that people delay, but eventually
right.
I wouldn't be surprised if that number's high. Okay, fair enough.
Well, my reason for asking this is that when you send the trauma data to me with the encounter number appended, and I join that to the VTE prophylaxis data, I would imagine that there might be some unmatched data between the two, which could indicate no pharmacologic prophylaxis during hospitalization. And they would then ultimately fall out of the analysis in the tables that I'm presenting here. But it's just that question sort of in advance, what we might as a group think that we would want to do with them if that happens to be true.
And it's a fair question of, do we include those patients who end up getting nothing prescribed for the whole duration of their hospital stay? Are we okay to exclude them completely from the analysis? Or do you think we need to put them in there somewhere?
I
Or
think we would have to exclude them from the analysis because they're not eligible for the intervention. You actually have to be prescribed a dose of VT prophylaxis in order to even be eligible to miss it, to then even potentially receive education.
I think that is certainly one version. The other way you could argue, and this is where I wanted the discussion, feel free everyone else to help answer. What if the idea is the intention of the intervention is to improve VTE for all admitted trauma patients to your hospital? So we're going to look at data for all of the patients, whether they're prescribed prophylaxis or not. You might be able to look at it for some of the outcomes, and you'll see what the outcomes look like. You might want to include the VTE outcomes or the mortality outcomes for all patients, while obviously the process measures you only have for the patients who are in the prescribed category. I think it's a good question, and as we come to those tables, we can clarify which populations those are.
One thing to just keep in mind, just because of Rosemary's reaction to 100% of patients being prescribed prophylaxis, could it be that if somebody is not prescribed prophylaxis, that they are so different that they shouldn't even be considered part of this population, that there might be so much heterogeneity in patients who are prescribed versus not prescribed prophylaxis that it warrants its own separate investigation?
It's a fair question. I think we'll also have to find out what the numbers are. I mean, what the really interesting part will be is if Rosemary is right and that at shock trauma, it ends up being 100%, and Joanne is also right, and at Lancaster, it's 90%.
It
it
may
might-
depend, like if you're, like you could be admitted for, I don't know, you need social work consult in the morning or what, something like that, and really have no
Totally.
injuries, and maybe you don't get VTE prophylaxis for that. Like it could be a not so straightforward question or answer at
Right.
least.
And maybe the answer is it's a secondary. And I mean, the nice thing about it is we're going to show you what we propose for the primary paper. Once the primary paper's out, there's this huge data set. If people have interesting other questions, this might be an interesting whole separate paper. Who never gets prophylaxis prescribed, and what happens to them?
So this is Joanne. So I go back to Rosemary, what she just said, because NTDB, their definition of a trauma patient, traumatic injury. It could be a laceration, but they're actually admitted for something non-trauma related whatsoever. But they happen to have this laceration because they fell after whatever happened.
That's a good point.
Let's say they're
Yeah.
intoxicated. Right. They're
Yeah.
intoxicated,
More you think
whatever,
about it.
And they may never, and they're not even on the trauma service, but they're still in our database. So do we include those patients? Because do we not include them? Whatever reason, neither here nor there, but they may not get anticoagulation. So they're up, they're walking around, they're just waiting for a placement, whatever, but they're admitted for a traumatic injury, such as a laceration. So
That's a really important point, because if sites are sending us data based on the floors that patients are admitted to, if they appear in the trauma registry, but they were on a floor that's different than where we were getting data from, they wouldn't appear in the VTE prophylaxis data set.
And that's the other piece about some hospitals sent us a wide swath of data, and some hospitals send us the narrow swath of data. And I think that will be another reason why we might not be able to match patients if they are admitted to a non-trauma floor.
Yeah.
Right?
Or non-trauma service.
Non-trauma service, and Rosemary, you don't really have that issue, right? Shock trauma, they all go to, trauma at shock trauma, but at other places like us at Hopkins and other places, yeah, they go to the medicine floor. An elderly patient with no injury had syncope goes to the medicine floor.
Yep.
So I think the interesting thing will be, what does the data show us?
So that's where I got my 80%, 90% right around there, because I know there are patients out there that are admitted, they're in our database, but yet they're out of my line of sight. They really are, because they're for laceration and syncope workup or whatever, intoxicate, whatever. So kind of.
And as someone who works at a place that's more like yours than, shock trauma is its own separate freestanding trauma center, versus all the rest of us work at a hospital that has a trauma center within it.
Oh, we try to get those patients to medicine. We just may not be as successful.
Right. And we have a different pathway, but I think it's a fair question of what do we do? And I think, Brandon, that's where it might have to be only the patients we match, but then the overall might be a secondary. We have more discussion about this topic.
All right. So what I'm
Do
hearing
you
is,
want to?
yeah,
what
I'm
show
hearing is,
some of the tables?
let me do a little exploratory analysis when we first get the data, and then come back as a group and see if we can make sense of it.
Okay, perfect. But I would
All
like
right.
to at least show people the tables.
Yes. All right, so next slide. Table 1, very much like Delphi, is very long and extends on multiple slides because I wanted people to be able to see this. So starting off with demographics, age, race, sex, and then injury severity by category, pre and post implementation. Severe injury defined as AIS greater than or equal to 3 for head, chest, abdomen, spine, extremity, and then some characteristics of the injury mechanism, and then physiologic characteristics, shock, GCS less than or equal to 8, mean heart rate, ventilator days greater than or equal to 3, the ICU length of stay, the median ICU length of stay, the overall median length of stay. Next slide. VTE risk factors that we think we might be able to get from trauma registry data. Cancer, there are 2 different fields for cancer, cancer therapy and disseminated cancer. There are fields for stroke and MI. There's a field for heart failure. If there are other fields that people think might be useful to include that relate to VT risk factors, I'm happy to share a link to the public use file where I got some of these from.
And I will say, Brandon and I, you know, there've been a few papers using a National Trauma Data Bank for risk factors for VTE. You know, Peggy Knudsen wrote the big first one. I've written one. There's a few other people. So we kind of started there as ideas. But if people have specific ideas that you know are going to be in TQIP data, we can certainly add them in if you think they're important.
And then for the purposes of the draft tables, and only for the draft tables, we have this identified now. This will be de-identified as site 1, site 2, and not necessarily in alphabetical order prior to publication. Simply as we're working through the data and understanding where there might be differences, so that it's easier for us as a group to be able to go back and discuss, rather than having to link back to a different identifier. But we will be de-identifying prior to publication. Similarly, de-identified prior to submission, but dose level characteristics, the doses given or not given, doses that are refused, doses that are missed for reasons other than refusal, presenting this as the overall and then individually by site, which again will be de-identified.
And this is obviously one of the critical outcomes that we have right here. You know, is there a change in that overall proportion from before versus after for the not given, refused, missed, et cetera? And then I think the difference by site is going to be an important piece to see. You know, if there is an overall benefit, is it similar at all the sites, or is there variation by site?
Dose level information by VT prophylaxis, dose and frequency. We thought that this could be an important thing to present, that there might be differences by different regimens. These are the initial ones that we thought to include, but when we actually explore the VT prophylaxis data and the different types of regimens, we'll give a frequency of how many different regimens exist out there, and we can decide if we need to expand beyond this.
Yeah, we know sites are using higher doses based on weight or based on anti-10A levels, et cetera. So don't be surprised if the newer version has, you know, a row for 50 twice a day or 60 twice a day. But generally, this idea of, does it matter what you're prescribed? Does the dosing frequency, is that associated with missed doses?
This is Rosemary. Just one quick thought on this. Are there any centers that are giving 40 Q12 as for everybody? Because I'm just wondering if the higher doses are, if everybody's only giving higher doses based on body weight.
It'll be interesting because we will be able to show you that. And then, you know, I think in an exploratory data analysis, we can look at that. You know, as a reminder, the new college and the Western Trauma Association recommendation is to start at 40 Q12 for the not elderly, even those not overweight patients. So I don't know what sites are doing. I mean, I'd be curious. We are still using 30 twice a day as our standard first dose. Rosemary, what are you guys doing routinely?
We do 30 also is standard. And then if I think it's greater than 100 kilograms, it's 40.
How about other sites? Is anybody here willing to say, yes, we start with 40 twice a day for the average patient?
We do that except for neurosurgery patients are 30 BID.
Yeah, and I think, you know, when we ask around, I think we have the protocols for each site. Lizette has collected those in the past. We could certainly look back on those, but also I think at some point, you know, the data will show us what it looks like. You know, if there's sites, you know, we're going to be, you know, if most of the sites are doing 31 twice a day, you'll be able to tell, versus if you are a site that has, you know, 80% of your people getting 40 twice a day, that's because that's probably your protocol. It's a good point. I mean, at some point, the data will tell us what people are doing.
And I actually just looked up in the participant use file, they do give height and weight.
Yeah,
So
I'm
we-
not convinced that's always super duper reliable, but it's something we could certainly, I mean, Rosemary, there's another great, secondary paper. Every question that gets asked that can't be in the main paper, there's a
Yeah.
secondary paper out there. And, once we have the main part done, if you have group people who want to work on it, whether you're the PI and want to write it, if you've got a resident, a postdoc, a fellow who wants to write something, we can certainly move it along that way too.
Okay.
The original CLOTT 1 had the main paper in JAMA surgery, and then has had at least, I would say, a half a dozen to a dozen follow-up secondary papers. Okay, keep going, Brandon. We're gonna get short on time.
So this is patient level VTE prophylaxis administration. Again, overall and by site, and sites will be de-identified before submission. Describing the patients who missed or were not given one or more doses, who refused one or more doses, or missed doses for reasons other than refusal of one or more doses, which is something that we've consistently measured. Are we seeing a reduction in those who are not given or not administered one or more doses, such that more patients are getting 100% of their doses?
And we've written a few of these papers, and I think the difference of a dose level versus patient level ends up being very, very important.
Next slide. So the VT and clinical outcomes, we included in our proposal that we would be exploring any VTE and then VTE that are associated with missed doses. But we also wanted to break this out as DVT only, PE only, those with both DVT and PE, those without VTE, all-cause mortality, and those who had VTE and received all of their doses. But then also breaking this out as VTE and refused only, missed only, or both missed and refused, as patients could have a combination of those during hospitalization. And last slide. This is a question that we have for the group on deciding what to count as the pre and post implementation periods, and whether we actually need to include other time points within the analysis. So we do have the date when the patient education bundle was launched at each individual site, which is clearly an indication of a post-implementation period. But in what it is that we've presented before, having nurse education, for example, made somewhat of a difference in VTE prophylaxis administration. And there was a bit of a period between when nurses started completing the education and when the patient education bundle went live. There were also different points that we were trying to get to of 40% completion, 80% completion. And we wanted to have a discussion with the group of what we think might be valuable to explore as different points that could have affected the trajectory of VTE prophylaxis administration.
And I think I'll just add on that it potentially gets a little fuzzy, right? So we know the date where the alert gets turned on, but maybe if you've educated a ton of nurses well before that, they've started thinking about this, they've started talking to their patients, they've started doing a better job of explaining it, even just based on the education. And we know education alone works a little bit, but maybe there is some effect. So when you actually turn on the alert, the effect that you think you're getting from the alert is actually attenuated. So then this question of, well, should we look at this? Is it a wash-in period from the first education to the patient education? Is it first, does it matter how many nurses have been educated? You know, do you see a benefit once you get 10%, 20%, 50, 80? I don't know the number. So we can pull these numbers, but I think it was an important question to ask, you know, the group, you know, do we just do a simple before versus after, or do we need to look at that piece of, does education alone make a difference in this group? And we also don't know how long this period is. Some we know, you know, the education started and it took a really long time to roll out the alert. Others, the education started and the alert rolled out within a month. So then it's less of an issue. I realize we are at time, but it's something to think about. We don't need an answer definitely today, but you know, more to come on this question of, is there a wash-in period? Does it matter? How long will that be? Will it be
It's a
different
tough
for different
question, Elliot.
sites? What's that?
It's a tough question.
I understand.
I'm thinking.
Well, and it's also not that I mean, you know, and Rosemary, I'll use you as an example, not to be mean, but I even said, you know, the way we have it set up
No, I know.
is
I know what you're gonna say. Yeah,
right? You got to 80% after your patient education alert went live.
yeah, well after.
I
Well
understand. And
after.
exactly. And that's the real world. This
Yeah.
is not a randomized trial, right? This is real world implementation. So what we're going to do is we're going to work with the center group, and I think Ashley and Lizette will help us try to come up with, you know, I think at least, when does the first nurse get educated? And then do these cutoffs seem okay? 40, 80? I mean, we just kind of picked them out of the sky. Like, are these, you know, or is it 50%? Once you have half the nurses, is that about the number to look at? We picked 40% because it's half of 80 and everybody got to 80. Like, I don't know.
But the other thing that I guess I'm wondering is the alert, you know, how does that play in with that?
Well, the alert, I mean, the main question is really the patient education. That's, you know, and we can relabel that where it says patient education column. That is the date that the alert went live.
Okay,
So that is the alert that drives the patient education.
okay.
And I think Brandon will have to we have to change that wording slightly to be the alert go live date. And then, so then the question is, does educating nurses alone before that go live date make a difference?
Yeah. I just have to look at it a couple different ways because I don't think there's a right or a wrong answer. It's not clear cut.
Yeah, and that's why we wanted,
Yeah.
you know, I felt like we had had lots of really good discussions about getting the data, all these other things. Now it's like, let the rubber hit the road. Like,
Yeah.
now we actually have to do an analysis, and we're going to have real data soon. So now we're thinking about what exactly does the analysis look like? And like you said, it's hard. And honestly, I didn't want us as a very small Hopkins only group to decide. That's where I thought it was important to bring it to this group to start to think about at least. And I think we're going to have at least one more discussion about this as a group, or we'll send it out and people can send back emails about opinions on it. But we thought this was as good a start as any. Like, when did the first nurse do it? When are we at 40? When are we at 80? But we put these question marks because it's like, they really are kind of I don't even know. Like, we just kind of picked a number out of our ear. So, any other comments on that idea? And I realize we're over time, we're going to finish up, but just so you guys understand where we are with this, the most important part is work on your data. Brandon's going to we're going to send around the information of how do you work on your data once you get it back. But I think for now, you can just touch base with your TQuip people, just so they know when they get this data file and they have no idea why they got it, make sure they know it's supposed to come to you. Can you go to the next slide real quick, Lizette? So as you can tell, we had a small participant group today. I think that's the July, August, summer issue. People are traveling. If people aren't traveling, they're covering clinical, etc. So what we've decided to do is we're going to cancel August, and then In September, we're gonna look at the qualitative data, the cost of implementation data, and then I would also put on there, hopefully, some of the preliminary data for the primary outcomes, those tables that Brandon just showed us. We're gonna potentially be able to start to fill those in. So that's, yeah, depending on if we have data by then, my goal would be yes, but if not, the other two pieces will definitely have data to be sharing. So thanks again for all your work, everybody. I think the big couple things now are get ready for the data and the matching and all the other pieces, number one. And then number two, Lizette's going to be in touch with you to make sure we have all the right people on the writing groups. Because now we're at the point where, you know, there's those first two papers I showed you are, like I said, 80% done, and the rest is moving forward. I just got a message about who's supposed to get the TQIP data. There's a slide there. It's on the slides. And then Lizette, did you already send that out to each of the groups? Should they have an email already with that list?
No. No, we haven't sent that out yet.
Okay,
That's going to be on Brandon's one pager, but I'm going to send out these slides right now.
perfect. And then this one pager is kind of like what Brandon just showed us, and it includes that list. It has the list of people, like at at Hopkins, it's Zach, whatever. And then obviously it'll be someone you guys all know very well. If it's not you, and you'll be able to get in touch with them. So, okay. Thanks again, everybody. I know we're a little over time, but here's what the list looks like, and this will go out for all the sites to get.
Yeah, I'll send the slides out so everyone has this.
Perfect.
All right.
Okay.
Thank you, everyone.
Thanks, everybody. Have a good summer. We'll catch up on email, and then we'll talk to everyone in September.
Bye.
Thank you.
See you guys.
Bye.